today, perhaps 4, because one doctor might not be able to perform today. However, I will introduce all of them for you first, so you get an idea for what you will see today. Basically, we prepared 3 peripheral operations and 2 coronary operations in 2 different hospitals. One in South China, one in North China. I would like to share my screen to show you a little bit about the hospitals and doctors that who is going to perform today. Okay.
陈永雄这个病人叫做男病人
1.25的吗？
是一个冠动脉钙化的一个病人，准备是延时针搏球囊的。
旧的系统
Okay,
是
so
吧？
I will show on full screen. I will show on full screen patient.
旧的系统。
So this patient with a history
那
of
拿旧的
ill.
系统吧。旧的系
So
统。
recurrent chest tightness for over 5 years, worsened for over 1 month. History present illness HPI, and the patient first experienced chest tightness without obvious factors over 5 years ago, with no associated discomfort. Symptoms relieved after self-administrative nitroglycerin in the past months. The frequency of chest tightness increased, lasting 1 to 2 minutes each episode and resolving with a little bit rest. So the coronary angiography at another hospital showed that the left main is normal and with TME3 blood flow, and the LAD is normal, irregular wall throughout diffuse calcification in the proximal to
他
middle
拿那
segment.
个旧的旋膜系统。
And the segmental stenosis up to 80% in the most severe area with TME3 blood flow. And LCX is normal development, irregular wall throughout diffuse throughout the vessel, and the diffuse calcification in proximal distal segment. And the focal stenosis for 40% in the proximal segment. Segmental stenosis of 90% in the middle segment, TME3 blood flow, and RCA with normal, but irregular wall throughout the whole vessel, and diffuse calcification and stenosis in proximal mid to middle segment up to 90%. Diffuse stenosis in the left posterior branch, and TME3 blood flow. So the medical history shows that hypertension for over 10 years with regular medication. No history of cerebral infarction, chronic emphysema, rheumatic heart disease, or myocardial infarction, or arterial fibrillations. Known coronary heart disease, denied history of hepatitis, tuberculosis, other infectious disease, blood transfusion trauma, or poisoning. So surgical history, there's just a coronary angiography. So no allergies. With the admission and diagnosis is the stable angina pectoris, coronary atherosclerotic heart disease, and cardiac function class 2, hypertension rate 3. So this is the patient that they are doing now.
这是做的右冠的一个电影。我们看
So
到
as you can see,
我们看到它这个病变的话，它有一个非常重的钙化，它也是一个很重的一个比较明显的狭窄。我们看其他的这些体位。
As you can see from the RCA, there is a very obvious calcification and a very obvious total occlusion.
大概在这个右冠的中段左右哈，看到一个明显的一个病变啊，整个血管的钙化也是比较明显的。
So in the middle segment of the RCA, we can see an obvious calcification and stenosis. Doctors, if you have any questions, if you have any ideas, just feel free to open your microphone and ask. Or if you're shy, you can type, of course.
Hi. Can you hear me?
Yes.
I'm Dr. Alior from Uzbekistan. I'm sorry, some technical problems. Will you plan before procedure perform IVUS?
OK，我们会那个做 IVUS 吧？
可以，我们准备好机器了，我们现在挂了指引就可以先给他做个 IVUS，再决定我们后续的一个血管的预处理的方案。
Yeah, thank you, Dr. Alias, for your question. Yes, they will, after this diagnosis, they will plan to use IVUS.
Okay,
And so
okay.
as to decide what's the treatment procedure after.
Okay, what about CT scan before procedure, CT scan of the heart and evaluation of calcification according to Egerton classification?
OK，我们会在那个术前做一个冠脉的那个CT 扫描嘛，就是确定一下它的钙化程度啊这样的。
CT 扫描我们是没有做的，我们从造影上面已经看到它一个很明确的一个钙化了啊，CT 我们就没有去做。等一下的话，我们会利用 IVUS 去确认它的钙化到底是在内膜下还是在在中膜或外膜的。
Okay, so the CT scan is not prepared because through the
不重，不是。
through the angiography, we can identify there is a very severe calcification. So we will later decide whether this calcification is in the intima or the
SALE，然后我们先做
external
SALE 先做 IVUS。
according to IVUS. So now they are preparing IVUS.
你告诉他们说，展示给他们看，边做边告诉他们说 IVUS 过不去。
my next
外院就
question,
是球囊，
what
那个不好
about
过，
use
过了，
special
它已
level
经狭窄
preparation of
地，
the
外院
lesion?
做造影有减轻的。
对对，所以我们的计划是 IVUS 能看就看，只是展示一下，不能看也不要紧。然后我们的计划是先磨一下，
OK，
先
刚刚我都没
磨一下，
有听到，不好意思。
然后那个 debulk 就是把那个斑块减容，
Sorry, Dr.
然后
Elias,
再
I
配
sorry I
合
didn't
那
listen
个
to you because the
IVL 的
doctor was
方案。
do some
OK
introduction.
So I'm sorry, my next question about plan
SALE
of
吧，
the
开 SALE。
procedure.
等一下，就转了一针
Sorry,
了，
go
没
ahead.
事。
What our doctors will you plan using of special balloons, for example, scoring or cutting balloon before the using ShockFast, or direct using will be
没事，
ShockFast
再干出
IVL?
吧。
OK, I'm asking.
We don't see it's a good idea to use a cutting broom or scouring something, and cause the crossability is quite poor, the resistance is high, so we plan to use a rotor abrator to debulk and modify the calcified lesion to make sure our IVL broom
我们现在在给他
can
做
smoothly arrive at the target lesion
SALE 的
and
一个
use the IVL to open up
我们先用
the
因为这个病人
tough
在外面已经
reason
做过
tough
多
reason
造
to
影
make sure
外院的
to
话
stand
是球囊是很艰
can
难的，球囊
be
是很艰难的突破。
smoothly
等一下我
delivered
们尝
and
试一
well
下
expanded.
有可能过不去。我们计划的话能过，我们先看一下 IVUS。
Before all this, we plan to try to deliver the IVUS catheter, but we are not very sure if the IVUS catheter can get through the lesion. After all, cause the patient was attempted in the outside hospital, and the outside hospital physician told us that it's quite difficult to deliver the balloon, and also the dilating balloon got a rupture at the calcified lesion. But anyway, the lumen, the vessel lumen is a little bit open up compared of the very original image. But our concern is maybe there is some tiny dissection there, and some crack of the calcium, and all that means the resistance is still high, and yeah, so we need to modify
指引给指引
the
开给我
lumen
吧，
surface
请把指引开
as
给我。
well as debulk it. So in this case, we prefer to
指引导师
combine the rotor and the IVL and the IVL techniques.
SALE， 然后一条 C on， 然后翻 cos 130。
So I see you well known. We use IVL, and when we define of deep calcium, yeah.
Yep.
And usually in our practice we combine it of rota and IVL when we see superficial and deep calcium, yeah.
Yep.
And we'll be decide final decision. It will be after IVUS. I see.
Yeah, that's a very good
用
idea. If we can
就
get
等一下吧，不
through,
着急。
we'll use IVUS to check everything.
先把指引开给我。
We'll
指引
use
和导师
IVUS at the very beginning, if we can. But if we fail, we will IVUS it after we rotor.
Okay.
Sorry,
My next question.
Oh yes, please go ahead. Sorry, it's very noisy in our CAS lab. Sorry. I have a question for you, Dr. Aliya. Doctor, my name is Yang.
Yeah.
Yeah.
Dr. Ali, can you
Aliya. Okay.
pronunciation? Yeah, it will be easy.
Yeah, I'm Dr. Yang.
Yeah, I want to ask you about intravascular imaging evaluation. What do you prefer, OCT or IVUS? We know IVUS good in calcium evaluation, but it's bad to the evaluation of deeping calcium. Yeah.
Yeah, that's it. But cause the the operation of the IVUS is simpler. So we use the IVUS for most of this kind of reason. I agree with you that the OCT is a good technique to acquire the information of the thickness of the calcium. Due to the complexity of the operation of OCT, so we rarely use it. And in terms of the thickness of the calcium, we use CTA. We use CT if we do it before the procedure. We use CT to correct the information. If we don't do CT prior to the procedure, we just use the angio. The plain angio also get us some information of the thickness of the calcium. I mean, when we do angiogram before we inject the contrast in a proper projection, we may get to know the thickness of the classification of the calcium and got some information of the distribution of it. Yeah. Here, I have a question for you, Dr. Ali. What kind of guiding catheter do you prefer to this kind of lesion, this kind of patient? What kind of guiding catheter do you like to use for it?
So if I understand you, you mean about using of guiding catheter selection?
Yeah. The selection of the guiding catheter.
In my practice, I prefer launcher guide catheters from Medtronic. Do you know? It's
Launcher.
very good for it's very good for support.
Okay.
And when we planning of CTO and IVL or rota case, we usually take of seven French guiding catheters.
Okay.
And also it's according to the type of rota ablation, yeah. We use 7 French in 1.25 and 1.5, and also types is 8 French. In this case, I think what type of guiding you select is not Judkins, right? Yeah.
It's not Jack. It's M plus. I'm not very sure if this is a short tip one. 这是个SLE 还是 LE? Okay, this is a launcher. This is a launcher SAL. I mean the short tip M plus left 1.0. That's SL1. It's a launcher, and this is 6 French. Yeah, 6 French. We usually use 6 French for the regular patient.
Okay.
Yeah. My question is like for this kind of cases, do you like a supportive guiding catheter or just a regular one? Do you think the
Yeah, of course. So I show some little NGOs, but I think it's Judkins writes it will be good if we take 7 French. But
Okay.
if we plan support, yeah, it's Amplatz guiding catheters. But my question about using of temporary pacing. You know, when we use rotablation in right coronary artery, we use temporary pacing. What about this type of using your mind?
Okay. The temporary pacemaking is not a regular practice for us. We now since during the years, I have no. I don't think we put any pacemaker, temporary pacemaker for the rotabration cases. Yeah, during the procedure, sometimes the patient suffers some AV block, but I like to say, to my experience, 100% patient can recover after we get a patient cough and yeah, I agree with you. There is some risk for the rotation to make a patient AV block or sinus stop, and that's the reason why we are always quite careful when we operate the rotation. For some high-risk patient, my experience is we just rotor for a couple seconds. I mean, the very short attempting, and stop and wait and watch. Wait and watch. We always, when we rotor, we always keep my eyes on the screen to monitor the rhythm and the blood pressure. But like quite a few years ago, we used the pacemaker for rotation patients, but nowadays we quickly practice. Thank you.
Okay. So this type of guiding catheter, it seems to me some dangerous.
You mean it's easy to induce some dissection, right?
Yeah. Especially osteal lesion.
Yeah.
In right, I think in this case, Judkins writes 7 French standard guiding catheter. It will be enough. It's my opinion.
Okay, yeah. Thanks for your suggestion. It's a good idea. I would like to wait for a few minutes to see if my colleague get engaged this guiding catheter. If not, maybe we can take your advice to exchange a 7 French sheet and 7 French guiding Judkins 4. Let me get my colleagues to get it ready, get the guiding catheter ready. 那个让他们准备一个，找一个7F 的右4指引，看有没有，好吗？
加不进去什么办法？
对，先准备。 I
来
just
深吸一口气，
ask my colleague, my
好，
nurse
好，可以
to
正常呼吸，
get the 7
正
French
常呼吸。
Jacquins 4 ready in case we need to exchange.
不应该
OK.
弹不进去，但是
鞘，切腹的鞘，切腹的鞘有吗？不用，准备好。OK. The Galen caster and the sheet is ready.
用切腹的该顶吗？计划是
你要不要换成切腹的右四呢？
可以，换吧，那就
随便你 ，up to you。
换吧。对。脚。
Thank you, Dr. Alia. Let's try your plan. Usually, we rarely use the we rarely use the Jacquins Galen caster nowadays. But I think your suggestion is reasonable.
Okay. Let's go to try.
Yep. Okay.
So according to our practice, we know femoral axis is usually not good for the right RCA cannulation. If you agree, yeah.
I'm sorry. What? Femoral.
when we use when we use femoral artery, it's some problematic to cannulation of RCA. Do you agree?
You mean the Galen caster or femoral what?
When we use femoral axis.
Oh, femoral. Okay, femoral. Yeah. Oh, yeah. Yes, I agree with you.
Some problem to the cannulation. It's very good from radial artery. Yeah.
I totally agree with
agree?
you. I agreed. You know what? For the physician like my age, when we were trained, we get access. We were trained for the access of the femoral artery, so it's easier for us to get it. But for the new generation operator, my buddies, the younger one, I mean the junior one. It's quite often, as you mentioned, it's quite often. The femoral access is not easy for them, especially to engage the right coronary artery. Yeah. Well, we know. Yeah. All of us. Yeah. Go ahead, please.
I want to ask you about femoral axis. Do you usually use ultrasound guidance or angiographic guidance? No.
Rarely. For
Why?
coronary, it's not always available in our center, and we always use our finger to touch. And but for TAVI, for the TAVI procedure, in case
it's mandatory.
Yeah, if we need a very strict and if we need to input the bigger profile sheet, we are more careful. But for the coronary, like 7 or 6 French, we always just use the finger compress and fill in and puncture. Yeah. But I totally agree with you. If we can use a echo guidance, it's a very good. It's a very good idea. Sometimes we get some difficulty to punch the vein the femoral vein, we have to use IVL. We have to use echo guidance because there are no pulse of the vein of the femoral vein, so we need to use echo. But for the artery, for the femoral artery access, it's very rarely.
I'm sorry, what type of wire do you use? Is it standard?
Let me check. 什么导师 Okay, it's a Sion. It's a Sion. You know what? Actually, for me, I myself don't like very much the Sion. As don't like to take a Sion as a workhorse wire. But
what type of Sion? Standard Sion or Sion blue
regular
or Sion
Sion,
black?
regular one.
Sion, yeah.
Regular one, 对。我们刚刚想用那个，我们刚刚用的 SLE， 它不好挂，然后那个老外他建议说用切腹的右式，我们就拿个切腹的右式试一下呗。是啊，我旋膜呀，常规用旋膜。行吧，我觉得旋膜也可以的，玩呗，好吧。来，你戴个耳机吧，戴个耳机。Doctor.
So, can you give me some information about type of IVUS will you use in this situation?
We use the IVUS. We use the science, the Boston Scientific IVUS.
Polaris or Avigo?
Is it Avigo? I'm not very sure. 我们那个 Let me check. 这个不是那 Avigo 是吧？还是我们旧的系统？波科。Okay. I'm sorry. That's the. I think that's the old system. It's not Avigo. Today we use the old system, old IVUS system. In Chichen, you know, Dr. Lian, my colleague, Dr. Dong, who is Dr. Dong, who is coming to take care of this this procedure. When he show up, he's kind of surprised that we use Drakins for getting cancer. A little bit surprising him, but I said, man, you just try it. Try something new, okay? I believe that must be okay. No matter the Drakins or the Sawtooth Empress.
Yeah, it's we know Judkins is not good for support, but when we use big friends, it's very good option.
Yes, especially we use a femoral access.
Yeah.
The Judkins is designed for the femoral access, so that's the reason why it's quite poor when nowadays use so many transradial case. The feeling is quite poor for the Judkins. And my idea, there is some experience for me. In the case
So,
we take a transradial access. I'm sorry, go ahead, please. 网络不太好。Some problem of the network.
I'm sorry. Can you show on full screen IVUS only?
Okay. You want to see the IVUS machine or the screen?
不要深呼吸啊，
It's
尽量
not
不要深呼吸。
那个 IVUS 有没有接过来？
引进。
接过来吗？哦，已经在那了。好的。Okay. Can you see the iris now?
不要
兄弟，
深呼吸，
先把那个这个倒影的图像打过去，先换倒影的，对，先换倒影。
这里 iris 通过，
我知道，没事，你
我们可以从这里先拉一下，这里钙化都挺重的。
as what we expect, the iris caster will get stuck at the proximate right coronary artery. Due to the high resistance, the iris caster cannot across. 好，现在转到那个 iris。好，再回放一下 iris 吧。Can you see the iris on the screen? We didn't see the very top lesion. We just iris the proximal sigma of the right coronary. So we give up the iris.
2.5， 20都可以。
不用扩了，耀辉。直接微导管换旋膜导丝。
是的，我现在就准备要
旋膜，
要压迫它进微导管交换。
太讲究了。
它前面有血管，把血管搞坏了。
Because we feel the iris, so our plan is to rotate directly. And Dr. Zhou is now get the trapping broom for exchanging the microcaster and the rotor wire. iris 不行，然后就肯定过不去了。但老外要看嘛，没有给他看一看。
后走了，不看了。
来，可以转到那个什么。Now Dr. Zhou is trying to deliver the microcaster.
So we have some problems, by connection. Can you hear me?
Yeah, but the signal is poor. It's not so through. Can you see the image? It's okay. It looks tough, but finally Dr. Zhou advanced the microcaster. Finally. Let me stop. Okay.
So I'm sorry. Can you hear me?
Yeah, now it's very good.
We have some problems, and I cannot see iris. Can you show me once again?
Okay, the iris is not a big deal. We didn't see the iris there. Okay, let's show again the iris. I mean, cause the iris cannot get through. So we got iris the proximal segment, the non-yield, non-diseased proximal segment. There are not much information of the iris. We can show again.
rotor.
Yeah, we just
So
yeah.
if you understand, it's a rotor wire entering, yeah?
Yeah,
Insert.
now it's a rotor wire.
Please give me some information about plan, our plan, type of bore and lesion preparation, type of wire, standard floppy wire or
Okay,
super stiff wire, and type of microcatheter, if you can.
Okay, this microcaster is 是什么微导管？
Because my NGO, it's not clear to me. It's
Oh,
some
sorry.
technical.
Yeah, oh, sorry. That's a regular microcaster, seems a Chinese homemade one.
你帮我踩的透视棒吗？
And the rotor wire is the regular one.
要帮我拿着外把。
I don't think they use a supportive.
拿着老师。
Okay. Oh, sorry.
Okay, 松手。
Sorry. The microcaster is not the Chinese one. This the Japanese. Fine cross. Fine cross 130 centimeter of length. The fine cross microcaster.
这不是成套的吗？
Yeah.
2代的，没有拿2代的旋膜啊。
With the fine cross microcaster, we just
为什么不拿
expand
2代的旋膜呢？
and input the rotor wire in.
Size of bore, 1.5.
The bird, yeah, the bird. We pick up a 1.5 bird. We have two for rotor rotation. We also have two systems. The new system of the rotor pro, but because we are out of the 1.5 for the new system, so now I get the old system, the rotor rotation. I don't think that's a big deal. Yeah.
习惯用2代就不要拿1代了嘛。
According to your plan, we have mixed calcium, yeah, superficial and deep, yeah.
I think so. I think so.
First step is rotational atherectomy, and after that, lesion preparation with IVL.
Yes,
yeah?
Exactly. Cause the regular balloon and the hours caster, even the balloon and the hours caster is very difficult to get through. So I don't think it's good to try the IVL balloon. Everybody know the crossability is inherited limitation of this kind of device. But use IVL can do something more than the rotor rotation. We can get the balloon bigger, we can get the vessel softer, easier to well expand, and get the stand roundly expand. Wait, 怎么样？
来测试。测试。我要踩住，胸。测试。对。
那佢已經講到導師㗎啦。
醫術。
已經講到導師啦。
16到17。16到17。漏气。沒斷漏氣。所以剛才大家意見就係話，即係第一佢係好雜，佢需要處理鈣化，咁咧就指引上點解選呢一個咧？有冇話？帶嚟係吧？開關呢？開關呢？在哪裡啊？
怎麼話？ 我哋不如全部睇睇下個先，要後背啊，咁樣係嘛？我哋全部完就再睇多。再講係咪啊？哦，好。頭先個 front cross 都好艱難咁樣接過去。因為我右邊是耳聾的，我是左邊，我是暴症性耳聾嘛，那時候他媽的，真是。哎，那邊聽不見我說他媽的吧？啊？哦，那不能隨便說的啊。OK， 不能說他媽的這個。对，啊 ，OK， 对对对，没事，好，来，杆数给够了没？
给够了。
啊，好，这是1.5的旋摩头吗？还是啥？好，没问题，啊，可以吗？接上了吧？没有吧？
拆开来检查一下。
不，等一下，不对，
他拿一袋的这是。
没，等一下。哎，你不是啊，都没接上。
对啊。
没接上，怼出来，都没接上。不，所以在体外就要出这个动作。
刚刚在测试的时候发现它转不动。
哇，你看，你都没接上，所以不能怼进去啊，都还没接上。
那个杨总，还需要忍一下吗？还是直接我们就说，有个主持人吗？
听到吗？
哎，杨总没在现场哟，没在会议。
现在是直接换吗？还是说怎么样？
各位朋友，大家好，我们是天津市人民医院血管科，我是血管科的刘红。今天呢，我们潘主任给大家带来一个价值动脉硬化第三层合并腰症透析的病人。那个潘主任呢，已经从左侧股动脉穿刺翻山，做了手术。现在呢，我们请苏大夫呢给大家汇报一下病例。苏大夫说。
Hello, everyone. This patient, Mr. Wang, is 56 years old. His chief complaint is intermittent claudication of the right lower limb for over 3 years. His past medical history, hypertension over 20 years, type 2 diabetes mellitus, over 20 years, chronic renal failure, on hemodialysis for over 10 years. History of cerebral hemorrhage 3 years ago with residual speech and motor impairment. Chronic heart failure. His surgical history. December the 4th, 2024. Left femoral artery puncture, left lower limb angiography, balloon angioplasty, Kaiser thrombolysis. On the 2024 December the 6th, repeat angiography and balloon angioplasty under local anesthesia. His specialized exam. No 那个 under limb edema, dusk skin, low temperature, and no artery or no necrosis. Skin tension preserved, no tenderness.
经历简单受一些。
OK.
CT 上没说。
His diagnosis is atherosclerotic occlusive disease of both lower limb, hypertension, type 2 diabetes mellitus, old cerebral infarction, and so on. This is his arterial CTA and 3D reconstruction. We can see his artery very severe complication. This is his CTA. Our surgical plan is left femoral arterial retrograde puncture with crossover to right lower extremity angiography. Prepare for right lower extremity shockwave balloon and drug and DCB therapy. Prepare for atherectomy and drug-coated balloon therapy. Prepare for arterial stent placement. Thank you.
我们看他们的界面。对，工程师怎么进到他们那个界面？
Can I ask you? Thank you for the information. Do you hear me?
然后判准，要不给他们试一下
Do you hear me?
造影情况。
Hello. Do you hear me?
能听见吗，判准？
Yes. Yes, I can hear. I can hear you. Okay. Can you hear me? Can you hear me? Can you hear me?
这边可以听见。Dr. Ali, Dr. Ali, the doctor asked you if you can hear him.
Okay. I have some questions about peripheral patients. What type of atherectomy do you plan at Jetstream? It's here, yeah.
给我来一个这个支持导管吧，这个好像管过不去。导管吧，支持导管，来个1v3的支持导管，1v3的支持导管，我看过不去。
Dr. Ali is going to use a guide support with EV3.
对。
No, you don't understand me. My question about next patient, which was presented with peripheral artery disease.
So you mean what kind of atherectomy that he is going to use?
Yeah. Because in the presentation, you show us information about preparation for atherectomy. Yeah. In your
这个来个支持
plan.
导管，
应该是刘主任吗？
来个支持导管，35 1v3的支持导管。
不是，他是说我们在介绍病例的时候说我们会用一个旋切，然后他是说我们用什么旋切技术？是潘主任这边是吗？
大旋切。
冠脉的。
一样。
Why I ask you about because in our practice usually we use Jetstream system for the atherectomy.
Jetstream 是这样的，就是那个杨德文，你能听到吗？
可以。
我们
是
计划的啊，翻山穿刺、塑造影， 断完之后，如果钙化挺重的嘛，用震波球囊去震。震完之后不好呢，咱就药头熄灯就结束了。如果是
就不准备用那个旋切，对吧？
如果不好的话，就背着旋切嘛。
旋切就是那个 rotor
对，
是吗？
还背
就是那个
shock 就那个咱们浩克那个和那个二代那浩克。
我听不太清楚。
这不是正说这手术策略了吗？咱们从左侧翻，
那个可以打一个震波了，因为这块很硬，这个钢块。
刚才看了看骨浅还行。
那你震波过得去吗？那球5毫米的球囊，我这支烧管过的，不行，那谁要放，不行，我拿一个3毫米球囊给贴了一下，那个震波好过，要不好过，我这支烧管是挺难过的。
有点吵，现场可以控一下吗？
那个3毫米的，那个3毫米短的，来个3毫米短的吧，短段的，越短越好。OK， 来回咪。
这个医生，就是那个，这个医生他问，我们是要用旋切，他是说我们一般会用什么样的旋切技术？他说他自己这边的话是用那个 Jetstream 是哪个牌子的？
方主任、刘主任可以听到吗？
我听见了，我听见了。
Hello，
他用 Jetstream 那是旋磨，还不是旋切，我们是用浩克系列的方块那个切除那种浩克系列。
底线。
我们是用什么
3杠20行吗，潘主任？
够了。
可以不可以？可以哈，3杠20啊。
对，底线。
行，打3杠20。
行，把这管出来。看180导丝，都来个180导丝。有
不要吧？
还要介绍一下这病例吗？
苏哲刚才已经介绍了。
不是现在的里面的情况。
这你就说吧，一边做，这已经跟通的了，一边做一边说就可以了。
最后那个
那么小孩，
上第二幅，那个上第二幅病例给我看，我放一下那影，往上看。上一幅影像，
你就直接用那个 DSA 上面看以前的图片来稍微说一下就可以了。
我是想放一下以前的图片，再往上一幅，再上一幅。
对，您直接用英文说吧。
OK， 杨海明。
可以听到。
Okay. Hello everyone. My name is Dr. and both of us. This is a classic angiography. The SFA of that's like this some segment of the public artery is closed, and we can see very severe constipation in the public artery. So we strategy to dilate this classification. We use the 3 millimeter balloon to dilate this hospital, and then use the ShockFast 5 millimeter ShockFast IVL to dilate this segment of the public artery. Okay, this is our set strategy.
So can we ask?
Yeah, go ahead.
What about using peripheral intravascular imaging? In this case, in your practice,
Peripheral intravascular imaging. What practice they will use, right?
Yeah. Especially in this case, I see you perform a CT scan before the operation, but we will know for the total evaluation, we need to perform intravascular imaging to know a type of calcium, deep of calcium, superficial or deeping. And after then, we will be plan it's a rotational atherectomy or IVL. So therefore, this question, do you use routinely peripheral intravascular imaging? If yes, how many cases per year? And what about in this case? You initially planning using IOS or not?
Actually, we seldom to use IVOS to classify to the diameter of the vessel. But we see the diameter of the vessel in order to the CT scan.
Okay, next question is technically, what type of wiring you try to insert?
别动啊！动完我都看不见了，140左右是吧？你去掉吧。
What type of wiring, right? What type of wiring?
呀，出来了。对不起啊，这个病人他总动换，他一动换，他把我的导丝出来了。
Yeah, leg moving is the main problem in these patients. Yeah, we need firstly it's adequate anesthesia, or we will be oriented in this type of patients to the calcium.
过一下。So right now we dilate this segment of the popliteal artery with 3 millimeter balloon firstly.
Okay, we see our question about type of wire and type of balloon.
那个潘主任他问是
0.18没出来呢。0.8 1.18 guide wire。
还有是用什么球囊？
这是什么球囊啊？这什么球囊啊？这是给我打的，这心脏的吗？This is a normal cardiology balloon 3 millimeter.
It's a coronary balloon.
Yeah, because it is very short, only 2 centimeter.
So it's a coronary NC balloon, yeah?
Yeah. 是不是可以用那个嘛了？等我做一下，可以把这个先给它个那啥震一下这块儿。对，我想拿这个给它扩一下吧，要不给出来吧，我这导丝给出来吧。等会儿我做个造影。
呃， 广东省人民医院这边已经旋磨好了，准备用震波球囊，要不先转到广东省人民这边来。
So, doctors, that the previous case, the coronary case, has been finished with the rota, and they are prepared to use the IVL, ShockFast IVL. Maybe we switch to Guangdong Provincial Hospital, People's Hospital.
Can you show me result, angio result after rotational atherectomy?
OK，我们转到广东省人民吧，然后先看一下那个是不是旋膜好了，对吧？就准备用 IVL 了。然后他说，
你别动。哎呀，
病人一直在动这边。
对，他腿，因为这病人啊是透气的病人，所以他的神经有点病变，所以他总一直在动。
Okay, because the patient in the Tianjin People's Hospital is always moving, so
哎呀，
a little bit difficulties.
你这个是过3-5导丝的呗？是过3-5导丝的吗？
先转到广东省人民还是怎么样？
还是1-8导丝？小万，
So, can you hear me?
可以过
Yeah.
1-8导丝的是吗？那你给我吧上吧，过1-8导丝就上吧，是过1-8导丝的吗？
对，你们快
上吧。
点转的话就转呀，不转的话就不转了。怎么在
啊，对，
跳跃呢？
4.5就行，4.5就行。
后台这边还是在天津，不是，现在是什么决定？如果要转的话，就天津这边画面可以先停一下，然后到广东省人民。
天津的医院声音先关掉。
So the next step we use 行啊。Next step we plan to use the ShockFast IVL to dilate the segment the subgluteal.
天津那边也准备用球囊了。
达到3.01，不是最大的3.5。但3.0打的不3.5，3.0好，哎，这里看注意一下啊，它在哪？你看我大概最地方大概它那边窗外好，这大概你
这是很重要的哈。
So this I was after rotational atherectomy, yeah?
看到吗？
这是用旋切之后的 IVUS。
Yes, I think so. That's the IVUS after rotor rotation and non-confined balloon dilatation. Just after rotor, even the IVUS catheter cannot get through. And I'll ask Dr. Dong to show the detail of the procedure.
好的。
老总戴耳机给他们介绍一下工作过程，我现在已经转过来了。
So how many runs did you perform?
什么？我知道。
Let's turn to Dr.
先
Dong.
我们吗？
He's going to introduce the procedure.
Hi. Yes, so I want to introduce our previous procedures. As we are using the guidance 7 French JR4, and with the support of this soft guiding, I think we cannot easily, the IVs cannot easily cross. Here, stuck by the proximal RCA, and then bird with we use a 1.5 bird the speed 19 yes, we rotate it with speed of 19 several times. I forget how many times I rotate, and with
7 times.
okay, maybe 6 or 7 times, and you can find first we rotate the orifice of the RCA, and we want to engage the deep engage RCA guiding, but still we cannot do it. So after we get a new rotor platform at the proximal RCA, I put forward the rotor platform at the proximal RCA to get more support for the middle, most severe calcification parts. So you can find, sorry. Yes, I begin the second rotor procedure here. You can still find a very severe friction on the middle part of the RCA. Poor engage, poor support from the JR4. How to solve this problem first? Move the rotor wire as far as possible, and then move forward the rotor platform. And third, try to deep engage RCA, and then I use a maximal rotor speed to try to cross the lesion. Did I do that? Yes. To check the good flow after the new platform. Okay, and then with a maximal speed. Okay. This with the speed of about 20.
Over 200 kilo.
You can find
yeah, cross, super.
Yes, I cross it with the left hand holding the catheter and the right hand to put forward the rotor burr. Okay, after crossing, and I polish the lesion with about 14 speed to polish it. Okay, after that, the angel, yes, the angel of the rotor, 1.5. Okay, some dissection here, but not flow limited. So I try the IVUS again. Still, we cannot cross it. Even I keep the rotor wire to get more support. And then I
now there is two wires in the
predilate with a 2.5
one is the rotor one,
NC balloon, and then after that, the IVUS can cross all the lesions. So what about, why not check the IVUS together? And we need some suggestion. 来播一下 IVUS.
Okay, let's show the IVUS.
播一下 IVUS.
Yep.
对
IVUS is on.
And you know, for the dominant RC rotor, sometimes will easily the hypotension or severe brady sinus cateterism, but it can easily recover itself, always cough. Okay. So after rotor and 2.5 NC balloon, you'll find some cracks made by the balloon or by the rotor. and in the middle, still even 300%, 300 degree calcification. So we want to balloon it with the IVL. So what's your suggestion about the size of the IVL balloon? 3.0 or even larger, because the EEM of the RCA is almost 5 millimeter, and the sphere stenosis part is about the lumen diameter is about 1.66, right? Yes. Yes. Okay, so what about your suggestion? Thank you.
Thank you for the information. Yeah, it's patient initially was to the mix approach, rota and IVL. It's good cracking calcium, but my opinion in this case, I will take firstly cutting balloon.
Okay.
For example, 2.5 or 2.75. After then, I will.
Okay.
ACT.
Okay, thank you.
In our practice, we usually use roding technique. Do you know?
You mean is the use of the cutting balloon or the scoring balloon, right? Before the IVL?
Cutting balloon in several time balloon inflation.
Okay.
It's named roding technique.
Okay.
It's help us to more crack calcium. After then, it will be easy to insert and delivery of IVL balloon, I think.
Okay, thank you. So what about the size of the IVL balloon?
IVL balloon minimally 3.0 or 3.5 because it's very big vessel.
Yes, OK。来2.75切割，来。
你真的要用切割吗？
他说的。
我不大同意。
那你要说呀。
不用，我们只是按自己的方案来就好了。
I think we rarely use a cutting balloon for so thick calcified vessel. My concern is once we cut, maybe some risk to cut the healthy side of the vessel wall. And
有没有进展？主要是没进展就行。是的，我感觉还没怎么进展。ACT 是吧
just shock it after rotor. That's my suggestion.
关一下麦。关了是吧？好，来，
关了吗？
郑波，
直接震。
In our practice, we more pay attention to aggressive lesion preparation. In all cases, when we perform rota, we obligatory using of cutting balloons.
OK， 可以开回我的麦。杨主任在说是吧？那就不用了。他说他常规会使用切割。
我们的常规不是这样的。
好，没事，你说就好。
OK。Our regular practice is without the cutting balloon. So let's try our option. OK。
来。如果是我的话呢，我就会使用1.75的旋膜。接着。但没关系，这个也是很好的选择。对，现在准备震波3.0震波，因为现在我的麦是关的，对吧？
你开着的，听得到。
我听不到杨主任说话，我听到有一个同事在说话。我说会场能不能听到我说的？
麦刚刚关了 ，OK。
不要，先把我关掉，不然待会乱说。来，帮我拿走先。
Let's try the IVL directly. Okay.
Dr. Ali, let's try the IVL directly because the Tianjin hospital is also prepared. So let's after finish here, we can go to there and see the peripheral case too. So let's move.
Okay. I think we still need some time to. 现在转到天津了吗？
天津那边准备的也差不多了，所以咱们这边先如果震波就先震波，然后就切到那边可能。那边已经切过去了。
现在切到天津了，我们多留影像吧。
天津这边是已经准备好了，直接用震波了，对吧？天津那边开个麦，天津那边同事帮忙开个麦。
对，你听到他怎么做的？
那个充电都得拿个转换头是吧？
天津那边同事帮忙开个麦，了解一下现场情况。
稍等一下，稍等一下啊，调一下麦。
如果待会儿那个球囊不好过，也要留影像，教一下这帮家伙。我不知道是说是法国吗，还是哪里
？OK 吗？
对，他要连这里没关系，他要连这里，连上就行，他这个就是一个。
And if I understand rightly, it's using of IVL balloon, yeah? With in picture I see how many shocks, yeah?
Yeah, I think so. Because they have prepared and they have inflated, just waiting for us to come back and for the shock. So I'm asking.
And how many shock pulses in standard peripheral balloon? More than 300, yeah?
More than 300, but it depends on the sizes and the lengths. So different one have different lengths, different pulses. 可以了吗？天津那边？
目前还不行，稍等一下，再调设备。
睡醒了。
要不我们先转回广东省人民那边，好像差不多了，是不是？
是的，是的，在震了。
转回去。
打开。
对，2.0的震。可以。是，也是2到4个大气压，2到4个大气压震起来。
镜头转过我们这边来了。这是个3.0的是吧？
要按就行。按下还是按？
So we back to coronary case, yeah?
前面有气泡。
Yeah, back to the coronary case because the Tianjin has some problems on the equipment of the microphone. So in this coronary case, we are doing the shockwave, the ShockFast.
广东省人民这边第一个周期已经震完了，Roy。
啊？
第一个周期已经震完了，广东省人民这边。
有点乱啊。
I'm sorry in advance, but technical problems with devices in China, to me, it's paradox. It's
It's okay. So they have finished the first cycle.
Okay.
Now it's on the second cycle.
Second cycle. How many pulses?
10 pulses per cycle.
可以。每个周期放了10次是吧
？8次好像。
是，
我也不知道。
OK。
可以听见吗？
可以听见。怎么又切到天津了？刚广东省在震啊。
We have finished the first IVL. Let's
这个得多震几次。
对，这是最重要的。
可以反复震的，对吧？是的。要等多久？
一条导管震完不够，再拿一条。
好，没事。
免费使用10条。
Is pressure is standard, yeah? 4 or 6 atmosphere, yeah?
高压 ST 抬高了。来先下。再多选一下。来上。出来了。然后打6个对吗？一起来的吗？一起来可不可以打？
可以打6个。
这个可以震
吗？可以震吗？也可以震。
老师别出来。准备
3.5这个。
是的。来，进点老师。
震了几个周期啊
5个。
局部那里震了3个。
要不要照一下？哦 ，Alice 也可以，Alice 也可以。
是的。好。
拿走，这个拿走，对，再把它拿走，这走。你在这里，赶快拿下去。解开这里，解开这里，赶快拿走。
好的，来走。
呢個好順啊！
呢度順。
你依家切角想切邊度啊？
钙化相对快的还可以。
我覺得高壓算啦。
不要。
小姐，切割沒有3.25這個型號。
嗱，啱好有藉口。
這裡還差一點，就中了這裡。大個鈣化好似冇斷。這裡斷了一點。
這是我們的是吧 ？OK， 打開
沒關係，放上去行，這個不影響。
可以了是嗎
After 6 cycles of shocking, the IOS catheter is very smoothly delivered to the distal, and we just check it. Okay, let's review again.
开口刚才是那一下了，开口，对，注意这一下，看看回左，来那朵，來3.5高壓。
哦，你想切呢度啊？啱最窄嘅地方喺邊度啊？阿敏？ I just ask my buddy to show where it was the tightest.
好，來3.5高壓。
What's your next plan?
3.5高壓。
Dr. Dong is going to pre-dilate with the 9 confine, but seems the narrowest 最窄那个地方你才 shock 了一次是吧？
It's mandatory. I will be take NC balloons for the final lesion preparation, and after then, and control IOS.
Oh yes. I think that's what Dr. Dong going to do. He just called the 325 NC balloon. After that, let's just ask him to IOS again. 人家要求说你扩完了再做一次。
上。非常好啊。
夠唔夠深啊？呢個位置？
排到10，待会我给你看你就知道了。
好，下。而家我冇同佢解釋啊，你知唔知啊？我哋喺度做緊啊，得。
So far, the non-current broom was well expanded except for this section. There's some eccentric calcium at the right side of the screen.
所以还好有这些手段哈，不然的话就更加没。
浴室收台，浴室收台。
漂亮，
好很多了。
远端那个狭窄也扩起来了，是吧？
非常好，
漂亮。
Okay. That's the angio after the NC perodilation.
你夏醫生嗰度㗎係咪啊？我董醫生啊。啊。我俾你睇下啦。OK， 我覺得我覺得可以支架了。
Okay, Dr. Dong want to stand now.
4.0吧，至少我觉得。4.0。
要不然3.5吧，用高压后扩就好了。
好的，我看看这个。
多大还不是取决于那个球囊。
差不多了，的确，因为我们这个才3.25的，对吧？
对，用3.5最长的吧。
好的，来3.5支架。
现在问题最长的。
没关系，合适就行了，那不一定长度的问题啊。但是我们有。
他在拿，做一下 IELTS 吧。闲着是闲着。
好，没问题。来，把它放好。
Our colleague is going to pick up a 3-5 longest stand. 不，支架来了，好快啊。
Could repeat please size of stand 3.0 or 3.5?
3.5. 你盖到开头都没问题了。
What about landing zone?
Yeah, that's also my question. That's also my question. Where's the landing zone? So, Dr. Dong, let me ask Dr. Dong, where are you going to land this story?
And I think 3.5 is small to this vessel.
I think so. 3.5 is small for this vessel, but after implant, we can get a higher non-compliant balloon.
What about IU sizing of the native vessel in distal part?
Yeah, it's also a good idea. I think Dr. Dong just want to save time.
And please some information about type of stand.
60倒影，60倒影。
I'm sorry?
About type of stand, what type of stand do you take?
It's a drug-eluting stand from Boston Scientific. We have Promus Premier, not very brand new, not very new generation. Because of the VPN, we don't have the new generation, you know.
Yeah, in this type of lesions, we prefer using of Megatron from Boston, yeah, also Tansei from Teruma, and also Onyx from Medtronic.
Yeah, I do think so. To agree with you.
Because in this type of lesion of radial force of stent is very important.
It is. But unfortunately, okay, we don't have so wonderful things. Also for us, Okay. Usually for us, the size of the stand of the metal frame is not big deal. Because with the post-dilating balloon, we can get it as big as what we want. But I do envy you, my dear friends. You have the new generation, so good stands. Okay, this I guess this is a non-compliant. What size is it? 这是一个高压球囊吗？对，3.5高压。3.5的是吧？是的，5、8、10、12。OK。
So NC balloon also from Boston, yeah?
I don't know， 这是什么牌子的？什么牌子的高压球囊？We are not always care about it. This is oh, this is a knee bar. This is knee balloon. That's Chinese homemade.
OK， 非常好。
Okay.
Okay.
漂亮。
係咪聖葉嘅虎門？係啊。
Do you have a special very high frequency balloons as well, like OPN, these medical balloons?
You mean OPM? Well, what we have in the CAS lab is the regular thing.
现在那个
不是说不
是的。
它本身呢，看一下啊。
不，本身应该没有的。有本身。
对吧？
对。
原来也有，非常好。
对。
更好了，来，艾维斯能进去吗？把手拉吧，手拉。好 ，OK， 来冲水。
Kepanı kaldırmak için. Tepede mi?
Dr. Dong is going to check the IVS with the manual pullback. I guess he's going to check the expansion and the age of the stand, the landing zone. There is some dissection at the very original proximal right coronary artery. Seems the crossability of the shocking balloon is fine.
这里啊。
折掉了，不用换了。我问一下那个董哥，要不要换？
用到應該
導管唔得係嘛？你近段唔再咩啦？近段使唔使再鋪多個？
佢嘅 angle 就好大，所以唔知邊個支架先合適，可能都冇合適嘅添。
OK， Iris 個 King 咗係嘛？我睇下我有冇私火。
好啊，因為你睇下嗱，好靚啊，其實做得。
嗱咁樣，你帶個耳機同佢哋傾下。好啊。我哋睇下仲有冇 Iris。
好啊。我個睇法咧就都好。
你帶個耳機，帶個耳機。好，幫董主任將耳機帶上去。幫董主任將耳機帶上去。Cause the IVS caster was king.
就是这个有点点，那个叫什么呀？
The IVS caster is broken. Now we discuss if we are going to finish this case.
我再骑一次。
用3.5、3.25 NC。OK。NC 对。
下醫生係咪做咗副院長啊？
天津人民现在那边现在是什么进度？主任，潘主任。
OK。
什么？是跟我说话
现在您那边，对对对，
我第一，因为它两
块，
块的这个非常严重的钙化，然后呢，第一个已经震波完了，第二个我刚超选到那个颈后动那肺动脉里去，刚超选到肺动脉里了，然后呢，我准备换成18导丝，我要拿第二个那个震波性能再扩一下它那个斑块，第二个大斑块，
你等
我不知道你看得见。
等下你在震的时候，我们再切到你这边来，好不好？因为这边。
你说什么时候再切？
现在准备震了吗？现在准备震了吗？现在。
我先把这个导丝到位，然后把球囊拨到位，我就准备震。我第一个部位已经震完了，
对吧？24、16、
28、
28。
好嘞，
现在在这个
现在已经切到天津人民了，然后要不您说英文再重新说一下是怎么样
？170，稍微等一下好。有4毫米的吗？震波球囊？
没有，应该是4.5最小。
最小4.5的。
对。
那就拿那个4.5的，我试试。来。
同时应该是到5期了。
哟，就拿4.5来，出来这个。保留导管、保留导丝这个出来。不，就拿这个，我看过去过不去，如果能过去就拿这个，拿这个扩吧。
现在天津人民那边的话是在做流出道了。
导丝往里头进点，再进点，对不对？再进点。OK， 可以，我可以说了啊。动啊！
现在切到广东省人民医院，然后董主任总结一下录影，然后线上的。
喂。
剪影在电脑影。
可以了。
我这个听不见，我这听不见。
NC with 3.5。
我是小孩，要打卫生。
So fully expanded. Yes. So, are you happy with the results? I think the orifice
进去看一下。
我这里也没有声音啊。
再前个音，再电一枪。
来个那个叫什么？
看这是
来个血气。
OK。血气，血气，血气。血气。
可能这个起来了，球囊不好用了，给我来一个新的。
热气来一个。
对，他刚刚是因为离远。可以做一个，那边做一个。
我就传了一个。
没有听到吗？那您再稍微说一下。
哦 ，OK。
对，不好意思。
现在可以听到吗？So we will review our standing procedure. As guided by the divers, we choose some 3.5. 可以吗？听的哦，我也不知道什么产品。
听得到，听得到。
我知道什么产品。哦，那个 ShockFast 那个是吧？哦 ，OK， 我以为你说那个支架要讲一下。那我 IVL 的过程我还需要讲吗？哦，对，我刚才没讲哈。So we use the ShockFast IVL with 3.0, yes, 3.0 ShockFast IVL. We shock it with about 3 or 4 times. First, we begin with 4 ATM to deeply inflate, deeply at adherence, good adherence of the vessel wall. And after that, we can see no severe dissection, and vessel preparation is can be accepted, I think. And I was check can find fully free cracking and no calcified ring here. So after the IVL, we go with the go on with the stenting 3.5 inflation, and with a high pressure NC balloon 3.5 for 13 ATM. Maybe a little undersized, underexpanded in the proximal and the middle part of the stent. And we use the same balloon with a very high pressure. Okay, nearly, almost fully expanded, I think. So this is the final. You can find a small dissection in the proximal of the aneurysm, but it's the same with the beginning. So we want to leave it alone, and no blood flow limited. So we can treat it with medicine. So that's the final result. Okay. That's all. Thank you. Thank you all the panels.
So this is all of the case, right?
摘一下。
Yeah. Can you hear me, Dr. Alio?
Yeah, yes.
Okay. Thank you very much. I'm
we
sorry.
can-
I'm sorry, cause the our tester was broken, so we failed to check the final result. We
Yeah, I see. I see.
yeah, we just discovered if we should put one more stent overlapped and cover the ostium right coronary artery, but it seems the lumen, the vessel lumen area is okay, and the so-called aneurysm or plaque rupture area was already there at the very beginning, so we decided to leave it alone finally, and that's all we did by Dr. Dong and Dr. Zhou, my colleagues. So we now finish this case, the case with quite severe calcified lesion that failed in outside hospital. We use rotation to debug and polish. After that, we follow with the ShockFast. We shocked for 6 circles and 10 shooting area circle. It seems the calcification was debugged and will expand. I like to say not perfectly, because there is still some waste, some eccentric way at the proximal coronary, but the area is quite, I mean, it's quite good. After the 3O stent implant and post-dilated, seems the result is not bad. So we just leave the rest around and put the patient on follow-up. This is the case from my center, Guangdong Provincial People's Hospital in China, and I'm Dr. Yang. So great to discuss with you, my dear friend, Dr. Ariel and every lady and gentlemen. Thank you very much. And next, after this case, Dr. Dong also have a second case. That's a peripheral. That's a peripheral one. Also very calcified. To my knowledge, the patient is on hemodialysis. So that's the reason why the vessel is so calcified. And we'll like to see you soon. Maybe see you in half an hour. And let's prepare for the next patient. Thank you very much.
So also we want to say thank you, for your team, for your job. Patients was really complex and really calcified. Patients initially intended to mixed procedure. So, and thank you very much for the great job. I think his angiographic result is satisfactory. And I think in follow-up, it will be good. Okay, thank you for the glad to meet with your meeting and some new information. And we want to say in finally invite you, your team to Uzbekistan, to our cat lab. And I think in the future we will be visit to your center, to your cat lab. Thank you very much.
I'm looking forward to that, and I also believe that we have chance to communicate face to face, and also looking forward some opportunity to invite you to China, my dear friend. Thank you.
Okay, see you soon. Thank you.
See you soon. Bye bye.
好的，那我们现在切到天津人民医院吧。后来
不一定用回那个传统，
辛苦杨哲，
人家压个眼嘴下去就行了。
下面咱是那个外交的，就得。
上一幅，再往上一幅，让他们看一下。往上，再往
对，
上，
方主任，
再往上，再往
再
上，
讲解一下，方主任。
最上面，最上，再往上，再往上。
若雨，你说一下，我们现在就回顾一下天津人民的治疗过程。
下一幅，再下一幅，再下一幅。OK, can you hear me?
So, okay, we are now like a retrospect the cases in Tianjin for this peripheral case.
Yeah, can you hear me? 听得见我说办法 Can you hear me? 听不见吧？听得见。Okay, this slide shows that the two segments of the public artery is occlude, and we can see the classification is very severe. So,